Hello everyone. I'm delighted to be here for this special occasion and to contribute to the launch of this important best practice pathway. The purpose of my presentation is to give you a whistle-stop virtual tour of the document. But before I do so, though, I would like on this occasion to start by acknowledging the significant work of the PRDA through its professional engagement team, medical advisory panel and steering group, but particularly to Leslie Smith, whose drive and dedication, hard work and gentle shepherding has culminated in this excellent document. Thank you to all, and especially to Leslie. So let's get cracking, and let's start by clarifying who this best practice document is for. It's aimed at healthcare staff, and its purpose is to act as a reference for clinical decision making, and it therefore uses medical terminology. The best practice pathway is applicable to any service that sees people who've had prior radiotherapy to the pelvic area, and you'll see a long list of professions here and in the document, and that includes the MDT across multiple medical specialties, including nurses, AHPs, and in primary care, as well as other relevant professionals. It will also be useful to health service policymakers, commissioners, managers, and researchers, as it provides information that will support a business case for integrated care for PRD symptoms, delivery of improvements in clinical outcomes, experience of care and quality of life, better recording of symptoms of PRD and identification of patients in hospital and GP records. And of course, this document will be useful to people affected by symptoms of PRD and their carers, as it provides information on how to seek help and what to ask for, and support to manage their own symptoms. What we want then, what we really want, is for you to start using this document in clinical practice. The best practice pathway document is aimed at healthcare professionals, so they may provide information on optimal ways to inform people about side effects of radiotherapy and self-care, identify people who've had symptoms of PRD, manage people's care in holistic, patient-centred and multidisciplinary way, and access professional education and clinical guidance on PRD symptoms. Throughout the best practice pathway documents are quotes from both health professionals and from patients, and the patient quotes in particular capture an essence of their lived experience, and they ground us to our purpose for improving care and services and bring this document to life. This quote is from Willie, a person affected by PRD. In this slide, as provided in the document, we provide the scope of the best practice pathway, what it includes and what it doesn't. So, for example, it's essential that recurrence or progression of cancer or a second or subsequent primary cancer are excluded before proceeding to manage the symptoms listed in this document. This document does not provide guidance on how to investigate if any symptoms are due to recurrence or progression of cancer or the appearance of a second or subsequent primary cancer, and this document only covers the long-term consequences of radiotherapy to the pelvic area, and therefore does not cover either acute side effects of radiotherapy or late effects of cancer treatment caused by surgery or systemic therapies. The best practice pathway includes sections given in this slide. The rhetoric is helpful as it provides the context, setting the scene through describing its purpose, its audience, how we may measure its success, its relevance. Importantly, it provides a definition of PRD, simply given as one or more ongoing chronic symptoms, variable complexity that may affect people who had previously had radiotherapy to their pelvic region to treat their cancer. It provides the multi-system features of PRD and the varying PRD terminology. It also provides associated PRD coding and search terms, and finally a section of getting PRD talked about. Now back to that section on terminology. Becoming familiar with the terminology used will be central in the implementation of this best practice pathway. In the document, you'll see there are multiple terms. It's important to be accurate when we use them. For example, the words ending opathy are better than itis because itis implies a short-lived inflammation, not a chronic dysfunction. There has been reported tendencies of clinical communities who are focusing on worrying symptoms in order to check for cancer or recurrence, such as rectal or bladder bleeding, are overlooking or ignoring other symptoms which could be investigated, diagnosed as a pelvic radiation consequence, and may well be manageable. We need to use the accurate terms so they are talked about and dealt with. The medical terminology around radiation-induced chronic symptoms needs ongoing debate so that standard terms are agreed and used, but the pelvic radiation disease is always helpful in addition, as it promotes the view of potential whole pelvic area issues, so that we recommend that in addition to any organ-specific terms, the term pelvic radiation disease should be used in medical records and correspondence. This acknowledges that often more than one organ or tissue, as well as mental health, are affected, and this will encourage a multi-professional, holistic, long-term condition approach to a patient care. Terminology is key. Now, this is an important slide, so if you're having a power nap right now, please do wake up and be alert for these key messages. The best practice pathway document summarises 5 things for you as healthcare professional to be prepared for. Number 1, know how to check for recurrence or progression of cancer or a second primary cancer. Number 2, know how to have conversations with your patients who have had pelvic radiotherapy, no matter how long ago. Number 3, know how to use this best practice pathway to manage symptoms. Number 4, know how to advise or signpost on self-management of symptoms, sources of information and advice. For example, in my own practice, I used a guide recently to help me assess a patient with radiation-induced lumbar plexopathy, and in another case, helped a patient with persistent hematuria who had been discharged from urology with no management plan once recurrence had been ruled out. Know how to advise or signpost on sources of peer support. And number 5, finally, be prepared by knowing how to make a referral to other services or clinics outside of your specialty. And this quote, specifically about radiation-induced vascular disease, but relevant to other PR problems, is why we need to be prepared. The key body of the best practice pathway document are the sections on symptom diagnosis and management, but before you reach that, there is guidance on how to use this section. Key advice is that each of the separate organ or symptom sections is not fully self-contained clinical guidance, but instead they point users to existing published guidance and best practice and to sources of education, information and support. Importantly though, as a healthcare professional, you're advised, whichever specialty or setting you work in, to consider each person's holistic needs and what actions could be taken to address problems across all their symptoms or issues. These are very likely to include psychosocial needs and the need for support for self-management, so the sections on mental health and well-being and self-management are recommended for everyone. And here's the case in point. May had treatment for cervical cancer and is now unable to have penetrative sex, and the impact of that on intimacy with her partner, with her body image, self-confidence, and so on. It's not just about the functional ability of each organ, it's about the knock-on impact on quality of life. Moving on, the best practice pathway includes this figure, which provides a generic flowchart for a patient who will receive pelvic radiation as part of their cancer treatment. Importantly, you will note that this begins prior to receiving the radiotherapy and emphasises the importance of shared decision-making, of the consent process, information giving of possible treatment consequences, self-management information, and the use of HNA and other prompts for assessment of patient concerns. As we move down through the figure, key time points in the patient pathway are given with appropriate actions for that stage. And now we might arrive at the meat of the document, the best practice pathway sections. Each section has a colour which is used for the edges of the pages to aid navigation, and in each of these sections includes information such as symptoms, incidence and prevalence, identification, management guidance sources, basic treatment and complex management referral. It also provides information on service models, quality standards and clinical audit measures and professional educations. When you use these sections, note that the sections are not fully self-contained clinical guidance, but instead use pointers to existing published guidance and best practice and to sources of education, information and support. A lot of detail is provided and no single person can be expected to know or remember all in the document. As a senior healthcare professional who leads a late effects service, I'm happy to confess I don't, and so this practical document has already helped me with more detailed symptom assessment, with supporting onward specialist referrals, and with providing self-management advice in areas where my knowledge was limited. In this quote, Willie describes the impact of his PRD on his everyday life. When reading this, it makes perfect sense that medical management and self-management should go hand in hand to benefit Willie and patients like him. Super importantly, the best practice pathway document contains a whole section on how to optimize a referral pathways. Please do read this section. Essentially, we acknowledge professionals may feel reluctant to ask about post-radiotherapy symptoms if they do not know where to refer the person to. Setting up established referral routes is therefore very important, as to give professionals confidence to ask about all potential symptoms of pelvic radiation disease and of other consequences of cancer treatment. It helps prevent people bouncing around the system, prevent unnecessary investigations, or prevent people being told nothing can be done. The guidance provided is designed to encourage small-scale change between local teams in order to ensure that people with PRD symptoms quickly reach professionals and the most experienced with PRD. In my own clinical setting, for example, I've challenged a local specialty which currently doesn't offer systematic services to PRD patients, but we now have a sit-down meeting scheduled to discuss how we're going to plan services for patients, and we hope you will do the same. Also in this section is a figure given here on the right, which gives a generic outline pathway for consequence of pelvic cancer treatment. It may not project in detail, but you will find it in the document for more further detailed consideration. The importance of optimising referral pathway is reiterated in this quote, lifted from the I Want My Life Back report by Joe's Cervical Cancer Trust and the PRDA. Finally, in the document, you'll find a section on how to increase discussion about PRD, given here in this figure. Do please follow it. We'd like you to take the baton back to your workplace, start using it, and start having your discussions with your colleagues and patients about PRD. But please don't put the document on a shelf or in a virtual file. It's our challenge to you that you start using it. So now you've had a tour of the best practice document, it's over to you. Good luck, and thank you very much for your attention.